Oh, thanks, Mark, and thanks, Dean, for setting this up for everybody. Yeah, as Mark mentioned, Jeff Hunnicutt, I'm the CEO with Highlands Oncology. Been here at Highlands for about 7 years, but been working in oncology for nearly 20 years. Working with a variety of practices, some of which are represented on the call today. So good to see you guys on here. Um, just a little bit about Highlands. If we go to the next slide. We're a rapidly growing practice. We're in a region that is it's one of the top 10 fastest growing areas in the country. So what we've seen in the last 7 years is going from just a little over 20 providers to 58 providers in 6 locations. Along with that comes a whole lot of referring physicians, and we're going to be talking a lot about referral chain today and how we've been working with Agamon to improve that process. But as you can see, nearly 1,400 referring physicians in our region. And we have a very robust imaging program with PET, CT, MRI, X-ray, ultrasound, a whole lot of stuff, and multiple devices across our locations. So along with that comes just a tremendous amount of volume with over 50,000 scans annually between those different modalities. So I want to level set as we go to our next slide and talk about some of the challenges that we have that are in front of us. Now, this is a call full of attendees who are running, are part of running oncology practices across the country. So you're probably going to look at these, and there's a whole lot of virtual head nodding going on behind the scenes. That we're all dealing with reimbursement cuts. We're all dealing with challenges from insurance and having to fight those battles and constantly having to go back to the table and pound our fist for contract renegotiations. We know that there are in many markets competition, whether it's from hospitals or other independent oncology practices, universities. In many markets, we're getting kind of breathed in on from all sides. Many times when we're talking about imaging, certificate of need or CON is a factor. And that goes state by state. State like Arkansas, we have CON, but it's limited to things that aren't necessarily inside the oncology realm. Things like nursing homes or skilled nursing facilities in the state of Arkansas, I'd have to get permission from the state before I would add that service line. Many others out there, though, have much more broad CON restrictions, where things like PET scans or CTs or MRI, those are all things that you would have to get state approval from, and that can be a really tedious and sometimes impossible process depending on which state you're in. We've all heard a lot about the uncertainty around the Inflation Reduction Act or whatever the next flavor of that might look like through Most Favored Nation and the newest administration. We've got a good handle on what the IRA will and won't do, but I think with MFN, it's very much up in the air because it pretty much was just thrown out in an executive order, but not much definition that I've seen at least yet to follow that up. What that does cement, though, is that we know that something's going to happen. We just don't know what it's going to be. That's not a very fun place to be. So I'd say that's definitely one of our challenges. The inflated cost of doing business, it just costs more to get supplies. It costs more to keep staff in the fold and caring for our patients. A whole lot of other items too, services that keep going up. So when you're combining that with the factor of reimbursement cuts and pressure from all sides, it's a challenging, daunting task. And then lastly, staff retention, especially in competitive markets where some of these key clinical staff, whether they be nurses or imaging techs, radiation techs, whatever it would be, there's competition over those same people. And so you see a lot of trouble keeping people on staff and keeping job satisfaction high because, let's be honest, the work burden inside of an independent oncology organization can get pretty stinking high. So those are some of the challenges as we move to the next slide. The question here is, well, how is Highlands using some of these newer technologies, some artificial intelligence technologies to address some of those challenges? And I've talked about frequently how this can be a very daunting task for us because I don't know about you guys, but my inbox, whether it's through LinkedIn or email or some other form, is just getting inundated with different tools and different offerings, frequently highlighting that they are AI based, to where it's dozens and dozens of these different tools that are coming out. For us, we want to look at these tools thematically. So we're looking at them essentially in 3 large buckets that exist within a practice, that being clinical, operational, and financial. So things that we are doing inside of, or either we're doing or that I've seen that other practices are doing inside of these buckets. Clinically, you see a lot of practices that are turning to ambient AI dictation. So essentially AI that's running from a listening device inside of the exam room, something like a tablet or a phone that is capturing those elements, transcribing them, and building at least the foundation of a physician note. That way the physician or the physician team can come through afterwards and kind of work through that process to fine tune it, make sure that it's accurate. You're seeing some other tools that are getting into the unstructured elements of the chart and are pulling different pieces of key information like supporting diagnoses or staging and surfacing those back to the teams so that they can be added into the chart in an easy way. I'm going to skip to financial. The big one there that everybody talks about is prior authorization. There are several tools that are out that are on the market that are marketing to address these needs. The question there is, well, which one of these is going to have the aptitude and the appetite to do more than just the prior authorization tool, to be able to step forward and actually distinguish themselves from the rest. And that's a common philosophy that we have when we're evaluating any of these buckets. We want to work with vendors who don't just have one good tool, but vendors who actually have this ability, the DNA or the shelving, so to speak, to do a whole lot more. Because I don't know about you guys, but I don't want to deal with 12 different vendors on 12 different applications. I'd like to work with one or two really good vendors and build out a host of suites or a suite of applications. The second bucket there is the operational bucket, and that's really what's more applicable and relevant to the work that we've done thus far with Agamon. Some of the things that we've done that we have in place right now, we have referral coordination up and running with Agamon. What that looks like essentially is that the AI engine is actually going into the unstructured element of our charts, and it's looking for orders that were generated or orders that weren't actually written or sent out, but they were documented inside of the note. And they're doing that for internal providers, but also external providers. So we can see that a referring provider may have sent us a CT scan, and the radiologist report showed that there was a 6-month recommended follow-up. Well, we're in month 7 and we haven't seen that order come back in yet. Agamon has helped to automate that process of identifying the high priority needs, surfacing those back to our team, but also automating a fax that goes out to that referring provider saying, "Hey, you're supposed to have sent us this report or this follow-up order. Please go ahead and generate that order." What we're actually seeing is that the referring community actually loves it because they're actually getting reminded of the elements that they needed to have in place to make sure the patient journey was up to par, was where it needed to be. So we're actually getting thanked for automating that process, which is a nice benefit, that's for sure. Some other things that we are in the process of working through with Agamon include chart prep and order completion. So order completion, I kind of hinted at that already as far as the referral coordination. But chart prep, obviously, that's something we all do. It's going in and combing through the unstructured elements of the chart and grabbing key pieces of information and bringing them back to the surface. Chart prep these types of technologies are a perfect fit for chart prep to be able to help to automate so much of that grunt, day-to-day, repetitive, rhythmical type of work. So we're really excited to be able to do some more in that space as well. So jumping to the next slide. Some current operational challenges. So what are some things inside of our practices? I talked about some big, national type of issues that are affecting us, but what are the things that are happening inside of our practice that would be, I guess, that would prompt us to want to look at AI solutions? I kind of already alluded to it, but manual reviews. In place of having AI to be able to comb through the chart and grab these different key elements and bring them back, our practice is spending a lot of FTE time, whether it be through medical assistants or nurse practitioners or physician nurses. We have physician nurses on our teams as well, and they're spending hours and hours and hours combing through these things. But it's a core part of their routine. So as we just build their work experience around these heavily manually weighted processes. So it's a challenge to be able to have to do that manually. Also, it's expensive to pay some of those people, especially the nurse practitioners and the nurses. Going back to the competitive element of trying to keep these people on staff, those salaries have gone up and up and up over the last 5 years. It's a tough pill to swallow from an administrative perspective to know that we have to spend the type of money we do on those salaries for them to be doing work that is fairly elementary, but it's just so important for the journey to be able to grab those different things. Another piece is care gaps, going back to what I was saying around the potential for missed follow-ups and yeah, missed scans to be coming back into the organization. Uh, Using AI to automate that process is a huge potential win for our group and for other groups as well. And then, for us, where we have a large imaging center, lost revenue. Let's be honest, if we have to be able to keep the lights on, so we have to be able to keep generating revenue. So if we're missing scans that are coming in from the outside, those are potential lost dollars to help to keep the practice afloat and be able to reinvest into our clinic to be able to build out teams and look at adding more solutions across the practice. So looking at the next slide, it's getting into some of the things that we are already doing. As I mentioned, the imaging follow-ups and closing care gaps. I think I kind of got ahead of myself a couple slides ago and detailed that a little bit earlier. But it is something we're very, very excited about. There's a tremendous amount of opportunity to step outside of imaging and do that with other key services inside the practice as well. So it may be on a future slide, but in the theme of being ahead of myself on these slides, looking at things like radiation oncology, even even infusion, some other things, making sure that we're grabbing those elements and bringing those key pieces of information to the front so we can avoid missing those care gaps and close them instead. Those are all things that we're really excited about that we're already doing with Agamon, and that we look forward to building out and doing more in the future. Another piece at Highlands, we have a massive lung cancer screening program where we scan right around 5,000 patients a year. So one of the biggest in the country. And along with that comes the need for very innovative software to help us manage those patients. So essentially population health type software where we can manage the journey, not just the scheduling of the patient, but actually teeing those data elements up for multidisciplinary clinics and things of that nature. Agamon has developed some very, very interesting technology on that front. And while we're not live with it at Highlands yet, it's still something that is very much on the radar for us to be able to fill a need and help us to improve in that element of care as well. And then last, like I talked about before, the visit and chart prep automation, surfacing those elements back up to the teams to be able to reduce the hours and hours that each team are spending the night before the next day, or whatever your process is looking like, to be able to build out those chart elements. I'm very excited to be able to get those elements off of their daily workload and free them up to be doing more impactful work. Next slide, please. So what does the business impact look like? As I mentioned, reducing time for MAs and APPs. They cost a lot of money, but also back to staff retention. It's not those hours spent on the grunt work are not exactly the most fulfilling. I would imagine if we're surveying our staff, they'd probably say that they'd rather spend more time interacting with patients and doing some of those things that probably are the reasons why they got into healthcare to begin with. So creating solutions to get people away from the mundane, repetitive tasks. It's going to reduce time, but it's also going to free them up to do more meaningful things, and I believe improve their job satisfaction as well. It's going to allow us by being more efficient and bringing data to the forefront to be more efficient and actually building out our schedules and make sure we're filling imaging slots, whether it's PET or CT, MR. And as we branch out and do this in more areas, we're going to be able to see that same value. And then, as I mentioned before as well, the procedure follow-ups, making sure that we're getting people in and on time. There's also a value-based care implication for that I'll get into as we go forward. But making sure that we get people in so that we can keep tabs on them, have them in the clinic in front of us, as opposed to missing out on a few months at a time. Things can change drastically in that way. And then lastly, MIPS. We all love MIPS. Or we all love to hate MIPS. That's probably more the way I would say it. But nonetheless, it's something we got to do. Closing the loop is one key element of MIPS. And the initial software offering that we've got in place from Agamon at Highlands is very much geared toward exactly that, towards being that assistant or that agent that is working through the process to make sure that we are blowing the doors off of the metric around closing the loop. And improving the patient journey as we go along. So next slide, please. So as I mentioned, value-based care, foreshadowing there. We have an opportunity by doing a better job of getting people in for their follow-ups. to make sure that we're staying on pathway or on the journey of knowing where they stand in their care journey at any given time. Now we do that with some cool technology like ePro and some other things too, but having a tool in place that's actually making sure that we get people back in for their scheduled imaging, that's massive because you guys all know at 2 months, 3 months, 4 months can make a whole lot of difference as far as what the outcome can be in a patient. And that inevitably will lead to more expensive uh, components of their care journey. So that it's going to be more hospitalization, it's going to be more ER visits. Um, and the further along we go, we know that stage 3 and stage 4 costs a lot more to treat than stage 1 and stage 2. So this is absolutely a key component for us to be able to drive our value-based care initiatives inside the practice. Obviously, the clinical quality component, we've already talked about that. Doing a better job of keeping the patient in front of us allows us to care for them better. So we know that we're going to do a better job of hitting quality metrics that are associated with some of these value-based care initiatives that our practices are a part of. And then lastly, sure, the MIPS. I've got a theme of talking about things before my slide comes up to talk about them, but as I already mentioned, it's something we have to do. And software like this really helps us to be able to accomplish that.